My best case of the year. So this is a 80-year-old gentleman presented with engine of exertion since 3 months, with worsening to class 3 in the last 1 week. He had undergone bypass surgery 16 years back, received Lima to LAD, SVG to OM and PD. Hypertensive, non-diabetic, echo showed posterolateral wall hypokinesia, mild MR, left ventricular ejection fraction of 45. So this was the angiogram. This was done outside 3 months back. So there you can see there is a critical distal left main disease, and it's almost 99% and calcified, heavily calcified. And LAD also distally there's no flow, and these are the graft study. SVG to OM is strict out. SVG to PD was flowing, a small PD. Lima was patent, but there was a CTO of the distal LAD. There's a diffuse disease in the distal LAD, and he was very symptomatic. With this study, 3 months back, done elsewhere, they had advised medical management. So he was on maximum dose of medical therapy, but he became very symptomatic, and for the past 1 week, he couldn't even go to the bathroom. So he used to get angina. So he came with this CD to me for a second opinion. So I told him that we could do a image-guided left main distal bifurcation stenting following rotablation, because I could see the calcium on the angiogram. And since he was an 80-year-old guy, critical left main bifurcation, so I thought he'd impella support. So he wanted some time to decide, obviously cost the issue, but within a week he presented with severe chest pain at rest. ECG was not unremarkable. Troponin was elevated. So we diagnosed him to have NSTEMI, started him on low molecular weight heparin, and they agreed for the procedure. So we planned, as per the plan, we took him, and we went with the Impella 2.5. And I took the shot. You can see the circumflex is occluded. That was the cause for the NSTEMI, and filled with clots there. So quickly what I did is I wired the LAD, dilated with a 1.5. It was very, very tough to pass any balloon, so 1.5 could go through. After the 1.5, you can see that circumflex has opened up. Not much of clot, I think. It was more of a lesion. So, and after that, I tried to pass the circumflex where it didn't go. Then I took a 2 millimeter balloon, dilated the left main again. Then my BMW workhorse where wouldn't go. Then I took a Fielder XT and negotiated the lesion and crossed the circumflex. Then I dilated the circumflex, then exchanged it with the BMW. Now I did an IVUS run in the LAD. You can see the distal, there is 360-degree calcium. Mid also there is calcium. These are all thin calcium, not much. And if you look at the left main, distal left main, there is a calcific nodule sitting there. It's a huge calcific nodule. So then I did a run from the circumflex. Not much of calcium. Yes, there is about patchy calcium in the circumflex, mid-circumflex. Again, the circumflex ostium, you can again see the nodule there. In the cross-sectional, you can see this nodule sitting there in the bifurcation. So we planned to do the rota. So we took a 1.5 millimeter burr, wired the LAD. So these are 3 passes I did in the LAD, and this is how it looks after the rotablation. So then I decided to do the IVUS and see what has happened. So post rota LAD IVUS run, so you can see partly the calcium is shaved off on the, you can see that here in the left main. So but still that nodule is remaining. So I thought of changing the wire into the circumflex and repeating the rota from the left main to circumflex. So I exchanged the wire into the circumflex and did the rota. 2-3 runs I did there, and I did a polishing run. After that it looks better. So now I prepared the bed nicely, took a 3.3 into 10 NC in the LAD and 2.75 and 10 in circumflex, dilated the lesion at high pressure, and I used an angioscull balloon 3.5 into 10 in the left main. So prepared the bed nicely, then planned to do a DK crush. So this is a 2.5 into 33 Zines alpine in the circumflex, deployed it, removed the wire and balloon, crushed it with a 310. Then this is the first kiss with a 2.5 NC in circumflex, 3 NC in LED. And I've done the pot. So deployed the 2 stents in LED. This is the 2.5 into 28 Zines Alpine distally and 3 into 33 Synergene LED LMCA. And this is the first pot with a 4 into 8 NC in the left main. So we got the measurements in the IVES. We knew it was a 4 millimeter vessel. This is the second kissing balloon. This is after the post-dilatation of the LED. So we post-dilated the LED entire stent at high pressures, and after that, this is the final kissing, then followed by second pot, final pot. So we did the post-stent IVES run. So you can see the stent is well expanded. And at the LED ostium, we had an MSS of 6.18. LMCA, you can see the calcific nodule is crushed to one side, and we got an MSA of almost close to 10, 9.68. Stent was looking very good, well opposed, and we got very good MSAs, and it was looking good. So we pulled out the wire, and I took the final shot, but there you can see there is a small dissection in the OM. So quickly rewired it and put a small 2.512 stent, Zines Alpine, and this is the final result. This is how it looks. So to start with, we began with a critical distal left main with occluded circ, and this is how it looks in the end. So I had twice during the procedure where there was a pressure drop when we did the rota. Majority of the time the pressure was very smooth with the impeller. I had to start a small dose of NORAD during the rota when I did the rota to LED and circumflex. That was a temporary support. After that, I just switched it off. So post-procedure, I pulled out the impeller. So take-home message, patient tolerated the procedure well with no hemodynamic compromise when on impeller. Impeller allows us to do a more complete revascularization and achieve good results. Meta-analysis has shown that mechanical circulatory support using impeller for high-risk PCI is associated with better procedural and hemodynamic outcome. Further large randomized studies are needed to know the long-term clinical outcomes. Thank you for your kind attention.
Thank you, Dr. Karthik. I think in this case, I don't think you could have done it without an impeller. So I think it's a very wise choice that you did use some form of circulatory support.
We decided, because on impeller we had a pressure drop. So no way, if there was no circulatory support, I think he would have crashed.
Yeah, this clearly depicts the how prophylactically if you use impeller, it saves actually lives.
Can I ask
you have to use it prophylactically.
Regarding, yes, please.
Why impeller 2.5, why not 3? Impeller 2.5 anyway is being phased out. We are going to be without impeller 2.5 in near
Cost
future.
issues.
Cost issue. And why couldn't you, was in inotropes after
no, before he was not on inotropes. When I started the rota, pressure dropped, I had to start him on inotropes.
And you used the same puncture site as the impeller, or you used a different?
Different. On the left groin, I went on impeller, right side I did the procedure.
Could have been combined.
Dr. Karthik, regarding excellent case, because I don't have an impeller in my center. If I want to do this case, whether my rota ablation strategy for debulking would have changed, because instead of using a rota ablation, whether I would have done the same with the IVL.
IVL, yeah, IVL was on standby. Both were there, and I had called them, and it was available. When I saw the calcific nodule at the bifurcation, I thought rota ablation would be better. Because if it is in the vessel, then it will push it to one side, but this is at the bifurcation. So I need to ablate it on both the sides. So rota ablation would work better.
Excellent case, doctor. One question. See, I thought the Lima was patent, right?
Lima was patent.
The Lima was patent. So would you have considered, just a hypothetical question, would you have considered standing from the left main to the circumflex and opening the distal LED because you have a patent Lima and made this procedure simpler?
Distal LED was diffusely diseased. It was like a CTO.
Even now it is diffusely diseased?
It was small collaterals were filling the distal LED. And he's very symptomatic. I thought it was because of the distal left main. And Lima intervention, going through the Lima and opening the CTO, I think this is better, I think.
But your wire went very easily to the LED.
Sorry?
The wire went very distal to the lady without any
Yeah.
significant issues.
It didn't go completely distally. It didn't go. It is one of the side branches it is packed.